Hello everyone. Today we are going to do a session on neonatal resuscitation. I'm Dr. Mahesh Devardhana, consultant pediatrician, currently attached to District General Hospital, Ampara. I'm looking after the level 3 nicu and the pediatric units. And I have my new trainees interns today who have recently started their internship appointments. So we are going to give them hands-on experience on neonatal resuscitation. So I start by giving a brief introduction. Sometime back, until around 2007, we didn't have a structured approach to resuscitate these newborn babies who needed help at birth. So basically what we are doing here is helping them with transition of these babies from intrauterine life to extrauterine life. So around 2007, Resuscitation Council in UK and European Resuscitation Council, they came up with this structured approach to manage these newborn babies who needed help at birth. So as you can understand, this is a emergency situation. So it's very important to follow the structured approach. So as a result, be it in UK or whether it is in Sri Lanka, in Colombo or Ampara, we manage these newborn babies who need help at birth in a similar fashion. So physiology behind resuscitation, I will touch that later on. But these were based on some studies done on mammals in early 1960s. You will have any idea like how often we have to resuscitate these newborn babies? How often do we get the chance to resuscitate these newborn babies? How common is the situation? So various studies have shown actually once in 500 deliveries only you will get the chance to resuscitate these babies. Right? So it's not very common, but you have to be prepared. Right? So having said that, myself and our NICU staff has managed 3 such babies who needed resuscitation at birth during last few days. So so always you have to be prepared. So preparation, so we'll move on to the next session, is the preparation for the resuscitation. So say like POG is taking a mother to the theatre because of a bad CTG. So it's going to perform an emergency C-section to deliver the baby because of this bad CTG. So now you are the person who is going to take over this baby, and how are you going to manage this baby, right? So that's what we are talking about. And until they deliver the baby, you have around 5-10 minutes left, so you have to be prepared. So how do you get ready? What is the preparation like? How do you prepare? So how do you prepare for this delivery? What are things you do? Sorry? Yes, good. So you have to actually to resuscitate these newborn babies, you need a firm surface, firm flat surface. In other words, you can't resuscitate these babies on a mattress. Right? So nowadays we have this machine called, you can see over there, the machine called Resuscitation. So it has all this timer and oxygen supply, sucking devices, overhead heater, lighting, and all things are there in the resuscitation. Right? So as you mentioned, you have to switch on the heater warmer early because it will take time to heat up. What else? Equipment will come to later, next next step is the equipment. So now we are preparing this preparation. What are the other things we do? So it's important to get the proper history about the mother. You have to be prepared, isn't it? So, this case we are talking about, so it's a bad CTG. So maybe like mother, there is a meconium still like maybe there. So you have to be prepared. So what are the other problems that mother can have? Huh? Sorry? Okay, right, if mother will get the what are the other problems in the mother which can affect the outcome? Okay, infections, so in that case, okay, we might have to start them antibiotics. Yeah, pregnancy induced hypertension, where the babies can be small, IUGR, and you might want to know about the Doppler studies, the umbilical vessels. What is? So diabetes, so which may affect your management. They can be either big babies or sometimes they can have IUGR. And especially if they are premature, whether they are term baby or not. So if they are premature, you have to be ready with the equipment, relevant equipment, right? And in that case, you might want to know about whether mother was given DEXA. See? So what are the other things you are going to do? So you have around 5 to 10 minutes for the baby to deliver. So you are preparing now. So first thing you should do is you should wash your hands thoroughly using the 5-step method, and then you can wear the appropriate PPE, and then you can what they recommend is to wear a pair of gloves, double pairs. Right? So what you do is you get ready with the stuff, then when the baby arrives, you remove one pair of gloves, then go ahead with the resuscitation. Right? So other important things are like you have to eliminate air current. For example, if the windows are open, you have to close it. If fan is there, you have to switch off the fan. And if there's AC, you have to make sure the temperature is like not very cold, like more than 27 degrees will be acceptable. Right? In our part of the world, it is not a big problem because our room temperature is roughly around 30 degrees Celsius. Right. What are the other things you need? We move on to equipment. So what are the equipments you need? Sorry, warm clothes, yeah. These warm clothes we have over here. Sucker tubes of various sizes, right? Sucker tubes of various sizes. So especially if there's a meconium delivery, you might need a large bore suction catheter. Right? Ambu bag, right? So this is the ambu bag. So you can tell us what are the parts of the ambu bag. So what are the parts? What is this? So it is the place where you connect the reservoir, right? Right? So what is the purpose of the reservoir? To increase the oxygen concentration we are giving, right? This is the port where you connect the oxygen supply, right? Right? So nowadays we don't start with resuscitation with oxygen actually. What they recommend is to start resuscitation with air, and if there is no improvement only, we are going to add oxygen. Okay? Right. What is this part called? So this is the self-inflatable bag. Right? So it will inflate by itself. Right? And then there are two valves here. So one is a blow-off valve. So if you give too much pressure, it will release that pressure, this valve. And there's another fish mouth valve inside. Right? You can see there another valve. Two valves, right? Okay. So then there are this place where you connect the appropriate size mass. Right. That is about the ambu bag. Okay. So this device is called Neopuff or TPs. Right? So this can be used instead of a normal ambu bag we use commonly. Right? So there are some components. There's actually this is where you should connect the blended air, right? Blended air. Then there are some adjustment knobs. You can control the peak pressure using this one. And this is the tube outing, and this device is the TPs, and you can connect this mask over here and give a using this device you can adjust the peak, and then like normal ambag you can, by pressing this you can give inflation rates as well as ventilation rates, right? So this is called Neopuff or TPs, right? So what are the other equipment you need? Drugs will come later. First we finish off the equipment. So laryngoscope. So this is the laryngoscope. Laryngoscope you have to make sure it is in the functioning order. Right? So this is where you put the batteries in. Right? So you have to have new batteries there, and make sure there's good light. So when there's a bad baby, you can't run here and there looking for batteries, right? So this has a good light. Right? And in newborn babies, in neonatal resuscitation, we use the straight plates. So up to 1 year of age, we use the straight plate laryngoscope, right? Straight plate. So these are straight plates of varying sizes, right? That is the laryngoscope. What is? So you can see the stuff here. Airways, right? Or airway agent. So mask first. So masks come in various sizes, and nowadays we use this silicone transparent mask. So you should have several masks of various sizes. So this should basically cover mouth and the nose. Right? It should not come out below here, or it should not compress the eyes. Okay? It should have a good seal. And again, when you connect the mask to the ambu bag, you have to connect outside and roll it over like this. Right? So you don't connect it on the baby's face like this, right? Okay. So there are various sizes masks. Then there are guidal, what we call guidal airways. So guidal airways, they are of varying sizes, right? So I hope you know how to size them. So usually mid-length is a angle of the jaw. So this is the right size for this one. And you insert it straight. You don't turn it like in adults. So we have varying sizes. Guidal airways. Then we have ET tubes of various sizes. So normal newborn baby of average weight around 3 kg, you can go for a 3.5 size ET tube, and you need for premature babies you need 2.5 size, and for bigger babies you can go for 4. So another device is laryngeal mask airway. So laryngeal mask airway, in a difficult intubation, you can go for laryngeal mask airway. Right. Then so those are for the equipments. Then we talk about now the baby is midwife has brought the baby over here. the baby is there. So what are you going to do now? What are you going to do? What is the first thing you are going to do? Yeah, whether the baby is crying or not, you have to get a dry towel and give a good rub, clean the baby well, especially the head, and then throw away that wet towel, right? Wet towel. Then take another dry towel and you can cover the baby, right? Cover the baby. And if you have a cap, you can put the cap on. As you know, babies lose heat through their scalp because they have a large head comprises large surface area in babies compared to bigger children. Right? So you can put a hat, cap, and then keep the chest area covered. Now, what are you going to do now? Sorry? Right, so actually when you dry the baby up, you can assess the baby in the meantime. So what are the things you are going to assess? It's color, tone, breathing and heart rate. Right? So whether the baby is breathing or not, we have to dry them up first. Right? That is the first step. Right? Then while doing that, you can assess the baby. Right? So say this baby is so what can be the color? What are the prognosis? Huh? Yes, baby will be pink in color, or it can be cyanos, blue, or they can be pale, especially if there's antepartum hemorrhage or placental abruption. They can be pale, right? Tone, what can happen with the tone? Tone, either they can have a good tone. So newborn babies, if they have a good tone, they will flex their legs and arms and cry vigorously. But baby with the poor tone, like if they are asphyxiated, they will have a poor tone. They will be very floppy. And mind you, if the baby is premature, baby, again tone will be low. Right? So that is tone, color, tone, then breathing. What can happen with the breathing? So, breathing, there can be regular breathing as normal, then there can be irregular breathing, or then no breathing at all. You will not breathe sometimes, right? So those are the things, tone, breathing, and heart rate. Heart rate, what can you do? Huh? So normal heart rate will be more than 100, right? So normal range will be 110 to 160. So how do you check the heart rate? Yes, you can use your stethoscope and listen to the heart, and you have to get used to that tone, right? So it's a good baby born in good condition have a heart rate like this. Like that, right? If the heart rate is like this, so that is not good, right? So heart rate is less than 100, right? So those are the things, right? So this baby is here now. We have assessed the baby. Color, this baby is blue. Tone, baby is floppy. Breathing, no breathing. Heart rate is less than 100. Now what are you going to do? So you can adjust the airway. So how do you adjust the airway in newborn baby? So you keep the baby in the neutral position. So what is neutral position? The neutral position is as the baby is straight looking at the ceiling. Or in other words, the baby's face will be parallel to the surface. Or in other words, angle line joining angle of the eye to the external auditory meatus will be perpendicular to the surface. Right? So as you know, most of these babies, newborn babies, usually they will have a prominent occiput. So if you keep them on a flat surface, their head tend to get, right, neck will get flexed. Right? So in order to correct that, what you can do is you can fold a towel to around 2 to 3 centimeter thickness, and you can keep it under the shoulder blades of the baby, right? So then, now what are you going to do? So you have corrected the airway, still baby is not breathing. Head tilt. So this airway opening maneuvers, head tilt and chin lift. Still open up the airway. Right? So then, if the baby is still not breathing, then you have to go for inflation breaths. Right? So there are 2 types of breaths we give to the baby. So newborn baby, the resuscitation, we start with inflation breaths. So inflation breaths are slow and sustained breaths which were given over 2 to 3 seconds. Right? Slow and sustained breaths. So you give them like this. Right? So when you hold the mask, you have to have a C and a E. These 2 fingers will make a C, and with the 3rd finger you make the E. And make sure your other fingers are not pressing on the soft tissues of the neck. Right? So you hold the mask from the base and put bit of downward pressure to get a good seal. Right? Then you count the inflation breath. 1, 2, 3, release. 2, 2, 3, release. 3, 2, 3, release. 4, 2, 3, release. 5, 2, 3, release. So those are the 5 inflation breaths. So what is the purpose of these 5 inflation breaths? Yeah. So as you know, when the baby is born, the baby's lung is full of fluid. Right? So what we are trying to do here is to push off this fluid from the alveoli and aerate the lung. So when you give the inflation breath, this fluid will go to the venous channels and lymphatics, and some amount will come through the airway actually. Right. Again, so even if you give the inflation breaths correctly, during the first 2 inflation breaths, you might not see a chest expansion. So when you are giving inflation breaths, always you have to look for the chest expansion. Right? So because the fluid is there in the lung, you might not see a chest expansion during the first 2 inflation breaths. Right. So you have given the inflation breaths. Now you what are you going to do now? So reassess. So after each and every intervention, you have to reassess the baby. So what are the things you are going to assess? Color, tone, breathing, and heart rate. Right. So now, say like when you give the inflation breath, you didn't achieve a chest expansion. What are you going to do? What are the other things you can do? Okay. Say the ambulance is functioning. Yeah, so you can use what you call this airway opening maneuvers, advanced maneuvers, where jaw thrust is one, right? So jaw thrust, you can use a single-handed jaw thrust, where you can push the jaw forward. You can push the jaw forward and then hold the mask, right? Then, if there are 2 persons, you can use the double-handed jaw thrust, right? So then you can keep your thumbs over the maxilla, then push the jaw forward. Then you can hold the mask with these fingers, right? Is that clear? Right. So other thing you can do, you can have a look in the airway. If there's anything obstructing, you can suck it out, right? Okay. Otherwise, you can use airway adjuncts also. You can go for a oropharyngeal airway, urinary airway. Say now, so there's no point in proceeding further if you have not achieved the chest expansion. Right? So then now baby has become pink after your intervention, but the heart rate is still less than 100. what I'm going to do now. No, this is the time you have to give ventilation breaths. Right? So heart rate, so there are some degree of improvement, but still heart rate is less than 100. So then you have to go for ventilation breaths. So these ventilation breaths are fast, right? 1 to 2 seconds. You count them as squeeze 1, squeeze 2, squeeze 3, squeeze 4, squeeze 5, up to squeeze 15, right? Then you will reassess. Okay. So after that, the baby is so there's a good indicator whether you are giving the breaths successfully is the increasing of heart rate. So if you have given the breath successfully, the heart rate will pick up. Right? So now the baby's heart rate has gone up, and then baby starts crying. So then what I am going to do? You can hand baby to the mother. Right? Say in a situation where the heart rate is still not picking up. So you have given the ventilation breaths also, still heart rate is below 60. Now what I am going to do? Yeah, so you have to give cardiac compressions. So how are you going to do cardiac compressions? There are 2 ways to give it. If there's a single person, you can give it with your 2 fingers. So just below the line connecting the baby's nipples, right? So 1 and 2 and 3 and 1 and 2 and 3 and 1 and 2 and 3 and 1 and 2 and 3 and, right? So if the baby is still not breathing, then you have to after every third compression you have to give a ventilation breath, right? So while you are giving the chest compressions, you have to make sure you are compressing 1/3 of the depth of the chest, right? Right. So again, then if there are 2, there's another one to help you. Then you can go for the hand encircling method. So hand encircling method, you put your hands around the baby, and then you press on the same place, just below the line connecting the baby's nipple. Right? So you press 1/3 of the depth, 1 and 2 and 3 and 1 and 2 and 3 and, right? This is fast, right? If your fingers are long, you can overlap the fingers and give it, right? So this is the best way to give the chest compressions, right? Okay. So when you give chest compressions with ventilation breaths, after 15th breath, then you are going to stop and reassess. Right? So still, if the heart rate is not picking up, so still the heart rate is less than 60. Now what are you going to do? So you have achieved chest expansion, right? Drugs. So this is the situation where you can give the drugs. Right? So how do you give drugs to a newborn baby? Yes. So when the baby's circulation is not functioning properly, not established, so no point in putting a cannula to the hand and giving drugs, because it will not reach the heart. So luckily, every baby has a central venous access at the umbilical stump. Right? So you have to make sure that these babies who need help, you clamp the cord, keeping some distance from the skin. Right? So you might have to cut and look for the veins sometimes. It may be difficult to find the vessels. So in that case, you might have to cut again. So you have to make sure you cut it cleanly. So how many arteries are there in the umbilical stump and how many veins? Yes, very good. 2 arteries and 1 vein. So how do you remember that? basically it's like a face. Right? Right? It's like a face. There are two nice rounded arteries, thick walls, and there's one big collapse vein. Right? So basically you have to put this catheter to this umbilical vein. So how do you do that? So it's an emergency procedure. So you have to clean the umbilical stump and then put a tie at the base, otherwise it can bleed like when you cut it. So put a tie at the base and then you cut it cleanly. Then you should be able to identify these vessels. Then you will gain access to the heart vein, and you can use either umbilical venous catheter or a small NG tube, size 5 NG tube. Right? So how long you are going to insert it? How far you are going to insert it? So normal term baby you can insert it up to roughly around 8 centimeters, and a preterm baby maybe 4 to 6 centimeters. But the standard textbooks will show you charts indicating how much to insert using the length from the umbilicus to the shoulder. Right? There are graphs. Right. So you inserted the umbilical line. Now what are you going to give? Yes. So you start with adrenaline. So we have the adrenaline wire here. So this is the adrenaline wire. So we have 1 in 1000 adrenaline. So we have to make it 1 in 10,000. 1 in 10,000 to give it through the umbilical vein. So how do you prepare this 1 in 10,000 preparation? You can do is you can take a 1 cc syringe and take 0.1 ml of 1 in 1000 adrenaline and dilute it with normal saline or water for injection until 1 cc. Right? The other way to do it is to take a 5 cc syringe, take 0.5 of 1 in 1000 adrenaline and dilute it up to 5 cc. And then how much you are going to give? So 0.1 ml per kg. So normal weight baby of a 3 kg will need 0.3 ml. Right? Always remember, when you give the adrenaline, you have to follow it up with the flush, normal saline flush. Right? Okay. So what are the other drugs we are going to give? Bicarbonates. Right. So bicarbonate, we have bicarbonate here. So how are we going to give bicarbonate? Yeah. So we have 8.4% bicarbonate in our units. So we have to dilute it 1 to 1. Right? So you can dilute it 1 to 1 and make a preparation of 4.2% bicarbonate. And with what do you dilute it? So you dilute it with 5% dextrose. 5% dextrose, and you can give 2 to 4 ml per kg. 4 ml per kg. What are the drugs we are going to use? So naloxone. Right. So we were talking about naloxone. So naloxone is not a resuscitation drug itself, but if the mother was given pethidine within 4 hours of delivery, we can give, and if the baby's respiration seems to be suppressed, you can give it naloxone. How much you are going to give? It's half vial IM. Sometimes that we used to give half IV, half IM, but now they recommend half vial IM. Right. Mind you, when you give naloxone, you have to monitor them. Right. So what are the other drugs we are using? Yes. Dextrose is another resuscitation drug. 10% dextrose. Right. So how much you are going to give? You can give 2 to 3 ml per kg bolus. And remember, they can get rebound hypoglycemia. So you have to always follow it up with the infusion. Right. What are the other drugs? So we have some other drugs here. So normal saline. So normal saline, we can like if the perfusion is not good, poor perfusion, and if the capillary filling time is poor, you can go for 10 ml per kg of normal saline. So in pediatrics there are several situations where I give 10 ml per kg boluses. What are they? Yes, DKA, dengue we give, yes. And in neonates we give 10 ml per kg. Diarrhea patients we go for 20 ml per kg. Right. So any other drug we have not mentioned. So rare occasions when especially if mother had antepartum hemorrhage, placental abruption, and if the baby is very pale, in that situation we can go for O negative uncross-matched blood. So those are the things, drugs we use. Any questions? If you have any questions, you can interrupt me and to clarify. Okay, now we will have a brief discussion about the physiology behind neonatal resuscitation. So I hope you all have seen this graph over here. So I'll briefly describe this graph, what is happening there. So what is behind it is like sometime back in early 1960s, they have done research on mammals. Using mammals, what they did basically was they have clamped the umbilical cord of the pregnant sheep, and the fetus is inside. What they did was they clamped the umbilical cord while the baby is inside the womb and observed what happened. So actually this graph shows what exactly happened. So this graph you can see over here, so it gives on the oxygen levels, carbon dioxide levels, acid levels, what will happen to the heart rate and the blood pressure. Right? So what initially happened, so this line shows time. And so you can see here like what initially happened was when they clamped the cord, umbilical cord, while the baby's fetus is inside the mother's womb. What initially happened was after like until few minutes, until around 3 to 5 minutes, they had this breathing movement. They started breathing inside. So the baby has not come outside yet. So this baby is having this respiratory movements while inside the mother's womb. Right? So after around 5 minutes, they will go to apneic stage. You call it primary apnea. They will stop breathing for some time again, right? Then after around 10 minutes or so, they will again start breathing movements. So these are not like initial breaths, they are irregular, spinal originated breaths, right? Gasping like breaths. And then after around 20 minutes or so, they go into a terminal apneic stage, right? So then they will stop breathing and the fetus will die, right? So in this time, what happened to these oxygen levels, blood oxygen levels is shown here. So initially it is maintained, later on it will go down slowly. And then carbon dioxide levels initially maintained, but gradually it will go up, and acid level will follow a similar course. And heart rate will be there initially, optimum heart rate, but then it will go slowly and it will stop eventually. And blood pressure also will follow a similar course. So what is the significance behind this? Right? So when a baby is born, and if the baby is not breathing, baby is needing support, actually we can't, just by looking at the baby, we can't say whether this baby is in the primary apneic stage or terminal apneic stage. But as you go on, so if this baby needs prolonged resuscitation, right? Prolonged resuscitation and lot of drugs. That means this baby is more likely to be in the terminal apneic stage. If they are in the primary apneic stage, they will need what they need is a small support. Just by drying them up and opening the airway will be enough. Small support for this transition. Right? Mind you, if you have to give resuscitate these babies for a long time, and if you have to give drugs, anyway their prognosis will be very poor. Right? So hope you have understood what is in this graph, and if you have any queries, I can clarify. Okay. So now we'll move on to some special situations. What do we do differently in certain situations? Like first one is meconium delivery. So how do you resuscitate the baby following a meconium delivery? So if the baby is crying vigorously, even if there was thick meconium, you don't have to do anything at all, right? So just dry them up like a normal baby and hand over the baby to the mother. But there will be a situation where if there is thick meconium, it can sometimes obstruct the airways. So this situation is a critical situation where you need someone who is experienced in intubating this child to help you, right? So if you are not experienced enough, always it's better to keep your seniors informed before you go for this delivery. See this VOG is taking this mother with meconium cell line for a delivery in the theatre section. So in that situation, you have to make sure someone senior is informed, get them down in the emergency, and you have to have large sucker tubes as mentioned before. Right? Right. So if they are not crying, and if they seem to be having obstructed airway, what you have to do is there are three ways to get the meconium out. So one thing is, what you can do is you can take a large flow suction tube, and as you know, like you hold this laryngoscope using your left hand, right? Sucking or intubation will be done with the right hand. You have to usually pull it forward to see the vocal cords, and then what you can do is you can guide the large bore suction catheter through the vocal cords and suck this thick meconium through the larger airways and the trachea. Right? So then you can proceed with the ongoing if the breathing is not adequate. So there are three ways to handle this situation. Other thing you can do is, if you have a ET tube and a connector to the sucker, like you can connect the ET tube to the sucker, you can again use that as a sucker tube. You can put it through the vocal cords and suck the meconium from there. Right? So last and the least effective method is you can intubate the baby, and then you can put a sucker tube through the ET tube and suck out the meconium. As you can understand, you can't put a large bore catheter through this ET tube, so it is the least effective method. Right? So, however, you should not delay the resuscitation. If there is meconium, if they are not breathing. So that is the about managing the meconium aspirated baby. Then another situation is preterm baby. So very preterm babies. So what is different in managing very preterm babies is what you can do is you can deliver them to a food grade plastic bag. Right? So you don't dry them up as usual. You straight away put them into a food grade polythene bag and keep the head area obviously outside, and then put them in the bag And then if you want to achieve access, umbilical venous access, you can put a nick there and access the umbilical vessels, right? So then once you put them in the polythene bag, you have to keep them under radiant warmth, right? Then you can take over the baby to the NICU in ICU, and then you can transfer the baby to a incubator. Okay. Then other special situation is birth asphyxia. So there are guidelines actually for this hypothermia, therapeutic hypothermia. So we have several stations in our country, in Sri Lanka, where they practice this therapeutic hypothermia. So if they're severely asphyxiated baby, if they are meeting this criteria, you can send them for therapeutic hypothermia, where they cool the baby's body, and then their research have shown the outcome, neurological, neurodevelopmental outcome will be better following therapeutic hypothermia. Right. So those are the special situations. Then what do you do next? Once you have resuscitated the baby, what is the next step? You keep them warm, and you can, if they are in a good condition, you can hand them over to the mother, right? But if you have to transfer the baby to NICU for further management, then you have to counsel the mother. You have to tell the mother what has been going on, what you have done, and you have to make sure that you keep them informed, parents, mother and parent informed, right? It's very important. Another important thing is following resuscitation, documentation is very important. You have to put the date and time, and you have to document things in a structured manner, right? So rather than writing apgar score, always it's beneficial to write down what exactly happened at 1 minute, 5 minutes, and 10 minutes. You can mention what was happening with the color, tone, median, artery at each time. Right? So documentation is very important. So in a summary, so we have given a small introduction, then how to prepare for the this newborn to accept this newborn baby who might need resuscitation, and about the equipments needed, and how to assess the baby, and how to give inflation breaths, ventilation breaths, and cardiac compressions, and drugs, how to achieve venous access, umbilical venous access, and physiology behind this neonatal resuscitation. And I have discussed some special situations, meconium aspiration, managing a preterm baby, and birth asphyxia, and importance of informing the mother and documentation. Right. So now we have come to the last bit, and I have to mention this about, I didn't mention earlier, about cord clamping. So nowadays we practice what is called delayed cord clamping. Right? So what is this delayed cord clamping? So you have to clamp the cord at the delivery 1 minute after delivery. So you have to keep the baby in a lower level than the placenta, and then after 1 minute you clamp the cord if the baby is in good condition. Right? So this will improve the, like in our part of the world, the anemia is quite common. So this will prevent the anemia, so it allows more blood to flow into the baby, right? So then you can clamp the cord and take out the baby. But in an emergency situation, if the baby is needing assist, for this transition, in that case, you can't do that. In that case, you can do early cord clamping, which is less than 1 minute, clamping less than 1 minute. So that is about cord clamping. And last bit is the practice session. So shows how to do inflation breaks. So make sure the baby is hold the mask with the C and E hold. Make sure these fingers are not pressing on the soft tissues of the neck. Right? Put a downward pressure with these two fingers. And, make a good C covering the mouth and the nose. Right? 1, 2, 3. Slowly. 1, 2, 3. Slowly. Right? 1, 2, 1, 2, 3. Release. Right? These are slow and sustained breaths. So over 2 to 3 seconds. 2, 2, press 2, 2, 2, 3. Release. 3, 2, 3. Release. 4, 2, 3. Release. Right? Do it slowly. 5, press 5, 2, 3. Release. So these are slow and sustained breaths. Right? So how do you give ventilation breaths? So they are faster, over 1 to 2 seconds. Squeeze 1. Squeeze 1. So you come and show us how to give chest compression. Yeah. 1 centimeter below the. Yeah. So you have to make sure you compress one third of the depth of the chest, right? And properly. 1 and 2 and 3 and squeeze 1. 1 and 2 and 3 and squeeze 3. 1 and 2 and 3 and squeeze 3. 1 and 2 and 3 and like that up to squeeze 15. Then you reassess the weight. Right? Is that clear? Right. So, okay. So you hold the base of the mask. These two fingers. This one is C. Right? So make sure these fingers are not compressing the soft tissues of the neck. Right? Okay. These are slow and sustained breaths. 1, 2, 3, release. 2, 2, 3, release. 3, 2, 3, release. 4, 2, 3, release. 5, 2, 3, release. Make sure look for the chest movement, right? Whether you have achieved the chest expansion, right? Ventilation breaths. Squeeze 1. Right. These are faster, right? Squeeze 2. Squeeze 3. Like that. So you do chest compression.
1 centimeter below the line. 1, 2, 3. 1, 2, 3.
Faster. 1, 2, 3.
1, 2, 3.
So your aim is to give 90 compressions and 30 breaths in a minute, right? 1, 2, 3. Squeeze. 1, 2, 3.
1, 2, 3.
You hold this one and then base like this. Right? You base. Keep the other fingers like there. Actually using the neutral position. Right. So slow and sustained breath, inflation breath. 1, 2, 3, release. 2, 2, 3, release. 3, 2, 3, release. 4, 2, 3, release. 5, 2, 3, release. Then one of so this time you are doing ventilation breath faster breaths, right? So 1. So if your fingers are long, you have to encircle the chest, and if your fingers are too long, you can like overlap like that. So 1 and 2 and 3 and firm. 1 and 2 and 3 and squeeze 1. 1 and 2 and 3 and squeeze 2. 1 and 2 and 3 and squeeze 3. 1 and 2 and 3 and squeeze 3. Okay? Is that clear? Go to the labor room. Right? So this mother had a bad CDD and they have delivered the baby using a forceps breathing. And the baby is here. Baby is not crying. So you can ask questions from me and show us what you are going to do. What is the first thing you do?
Check if the patient is breathing.
You have to dry the baby first. Dry the baby, throw away the dry towel, and use another dry towel and cover the baby. Right? Okay. Put a tap. Right? Okay.
Position the baby.
Neutral position.
Position.
Okay. Okay.
Then we, if still we give jaw trust and make the airway open. Then
So you are just assessing now, right? While you are trying to baby, you are assessing, right? So now I give the parameters. So color is blue, tone is sloppy, breathing no breathing, heart rate is less than normal. Now what I want to do?
since the patient is the sinus, we need an airway. We will check if the airway is patent and we'll start ventilation.
Inflation test. So give the inflation test.
We check if the appropriate mass size.
Yeah.
We'll count the face and the nose, not extending to the chin. We'll make the C and give support from
Maybe open this closer.
without using on the legs. We keep the position.
Yeah.
We give ventilation beds.
Inflation test first.
Inpatient beds are inpatient
1,
beds.
2, 3, release. 2, 2, 3, release. 3, 2, 3, release. 4, 2, 3, release. 5, 2, 3, release. Actually, the good thing about neonatal resuscitation is most babies will need drying up and the inflation rate, they will start crying, right? So after inflation rate, heart rate has picked up a bit, but still less than 100. Breathing is irregular. What are you about to do now?
We can reassess the baby and we can give intervals to the heart rate.
So give the ventilation rate. How long you are going to do? 15 hours. Yes, ventilation rate. Squeeze 1. Squeeze 2. Squeeze 3. If the heart rate is still low, less than 60,
Then we start cardiac compression while entering the ventilation. If we have another person, we can ask to give the cardiac compression. If not, we can use 2 fingers to give the compression.
so if you are alone, you can give single-handed jaw thrust and hold the mask, and you can give compressions from here. So you can move, right? And then 1, 2, 3 squeeze on. Like that you can give, right? But ideally, two people are there. Easy. Good. So good thing is like most of their most babies will need just opening the airway, right? The airway. Few will need breathing, inflation, that's ventilation, and circulatory support. Very few will need circulatory and drugs, right? Even when you give drugs, like prognosis will be poor. So how do you decide when to stop the resuscitation? So usually it should be decided by a senior clinician, medical consultant, or more senior person around the place. Right? So if you have to resuscitate this baby from, so it varies from institution to institution. So if you have resuscitated more than 20 minutes, then you have no point in continuing it, right? Even though the baby recovers, like they will end up having a lot of neurological issues. So other thing, if they are very premature, like less than 23 weeks, then after discussing with the parents and with the senior consultant's opinion, we might not resuscitate those babies. In other situation where if they are having congenital abnormalities which are not compatible with life, in that situation you might not resuscitate those babies. Right? So Russell, another scenario. So you are called to the theatre. So you are gone for an elective section, and then baby is having problems with breathing. Right? So you can ask questions and I will answer. So the baby is here. Midwife has brought the baby here. What I want to do?
So first I will dry the baby and keep the baby in the warmer and cover.
Yes.
And then I assess the color, tone and breathing and
Color. So color is blue. Tone is low. Right? Tone, but baby is very floppy. Breathing, there's irregular breathing is there. Heart rate is less than 100.
So start ventilated breaths, and I would
Before
that I will check whether is there meconium.
No meconium. But you can see a scaffold abdomen.
So I will suspect maybe diaphragmatic hernia.
And the heart sounds are deviated to the right side.
So I would suspect a diaphragmatic hernia.
So what would you do?
Auscultate and inform the seniors.
Yes, so inform down your seniors, and this child needs early intubation. Because if you ambu them, it will distend the bowel and make things worse, right? So you have to put a tube in and ambu, right? So some people think that you can't resuscitate babies if you don't have the skill to intubate. So that's not true. So you can resuscitate more than 95% of babies without intubation. Right? Even though if you can't intubate, you can manage these babies until the help arrives. Right? So most of the occasions you can ambu them. Right? Right. So it's amazing. Right? Another last. So you are in the labor room, and this baby is now fully dilated. There's thick meconium, right? And baby is just delivered and brought to you. So whether the baby is crying or not, you have to tie the baby up, right? And throw away that wet towel and cover the baby with another dry towel. In the meantime, you are assessing the baby, right? So color, I will mention color is blue, tone is floppy, no breathing, heart rate is less than 60. Just thick meconium.
Inside the mouth, they are just removed if the throat have to put bandages
So this situation, if you are a doctor, so always at the labor room itself, before delivery, when the mother is fully dilated, and they are telling they are thick meconium. So in that case, you can then and there inform your senior and get him down. This will take some time for him to come to the labor room. So always inform them early, so they will be there. And in this situation, you have to intubate and succumb this thick meconium through the apparatus. Otherwise, if you try to ambu initially, this thick meconium will go into the lungs and alveoli and cause chemical pneumonitis.